Learn about the critical role of diagnostics by visiting Biomarkers' Medical Education Hub. Watch webinars and tutorials, access online courses, and download educational booklets developed in collaboration with renowned experts. Go to biomarkers.com to begin exploring.
Hello, everybody around the world. I'd like to welcome you to the next session. Before we get started on the session, which is for the role of biomarkers in the early detection of sepsis, and we've got a great lineup of speakers, I'd just like to acknowledge and thank Biomarker for sponsoring this session. They are the sole sponsor of this session, and we're grateful to everybody, and you can see the slide there. So thank you very much. Without further ado, we're running a few minutes late. I've had some technical issues here. I'm going to pass over to our first speaker, who is Andrew Argent, who's joining us from Cape Town. He's a pediatric intensive care unit professor and is going to talk to us about his talk on biomarkers. Thank you, Andrew.
Thanks very much. Well, good afternoon to everyone, or good day to people across the world. And it's a huge honor to be speaking at this session. And thank you to the organizers for inviting me. My context is talking about biomarkers in the setting of pediatrics, and particularly in low resource settings. And clearly, biomarkers have huge potential use in the management of sepsis, ranging from identification of the different pathogens, looking at the clinical pathway that's expected, monitoring response to therapy, through to early termination of antimicrobial therapy. Of course, in the setting of low-resource countries, we need specifically to make sure that the biomarkers, while being accurate and accessible, are also reasonably affordable. And so as we talk about clinical implications, we need to bear those in mind, although potentially for the research implications, there might be a different perspective. Now, the context of children in low resource settings is that there's a very high incidence of background conditions such as malnutrition. And these children have often been exposed to a wide range of pathogens from early on in life, which possibly means that they're going to be responding in different ways, and that their responses will be mediated by those background issues. Of course, most of the research that has been done on sepsis has been done in high resource settings, and you can see the contrast between the high and the low resource settings. Just again, to highlight some of the differences between the clinical presentations, here's data that comes from Europe, looking at children who present with pyrexial illnesses and following them through for the presence of severe bacterial infections. And here you're looking at a continental-wide study recruiting some 38,000 children presenting to emergency departments. And of those, you find that the mortality is 0. A total of 0.1% of those children actually end up being admitted to ICU, and only 4% actually being admitted to hospitals. So the profile is one of early presentation, not huge numbers of patients. And when you look at the profile of pathogens and syndromes that were identified in that study, you're talking about bacterial, viral, and very few other pathogens, and even the bacterial pathogens are of a relatively small group of pathogens. By contrast, here's some data from Malawi, and here you have some 12,000 children collected in 1 year from one emergency department in Blantyre. 5% of those children were shocked, and of those who actually presented with shock, there was 11.9% mortality. So the children are presenting later. And when you look at the conditions they're presenting with, you've got this big chunk of malaria, you've got a lot of viral disease, but also lots of bacterial pathogens, many of which are not actually the same as are seen in the richer countries of the world. And so you have this different range of pathogens that have to be taken into account when looking at the diagnostics. When one thinks about where biomarkers can be used, quite honestly, if a child presents in extremis with presumed infection, the biomarker is not terribly useful. You know they need to start therapy. You're going to start with a wide range of things. If they present very early in the condition, it's very difficult to use biomarkers because potentially you would be doing tests on thousands of children with very few that actually needed a response. And so the place where biomarkers really makes an impact is on the set of children who present in the gray area, where you're not sure and where something might make a big difference to your clinical assessment. And of course, once you go for the biomarker, you're looking for different things. One is to identify the pathogen. Is this bacterial, and would this be a resistant one? Could this be viral? Could this be protozoal? You're looking at a later stage to see how is this disease progressing? Are the biomarkers going up, going down? What is the response? And you're also looking at the end of the process to say, is there evidence for de-escalation? Do I have evidence that I could switch off the antibiotics, that I could stop certain therapies? And so biomarkers are used in different contexts, but particularly in the poorer countries, we need to focus on those in the gray range. There's clearly a wide range of biomarkers, from ones which are relatively simple with hematological indices, such as the red cell distribution with nucleated red cells, but one that's probably been used more often is the presence of nucleated white cells. These are biomarkers, they're hematological responses, and are relatively inexpensive. So those are some that we could be looking at, and some biochemical responses like lipids have also been shown to respond to sepsis. And then one gets into the whole range of individual proteins, things like procalcitonin, CRP, through to genomics, transcriptomics, proteomics, and metabolomics. And you can also look at markers of the pathogen and also what the host is producing in response to those. Rogers and others have put those all together, and there's a wide difference of complexity in how those are actually assessed. For some of those tools to really assess them, you're needing artificial intelligence, you're needing to compare many of them together, but they could give incredibly useful and detailed responses, information about how patients are responding and how we should be thinking about treating them. The main ones seen in pediatric sepsis are things like CRP, which is easily available and relatively low cost, but the problem is that there are delays in its response, and perhaps it's more useful to be using towards the end of the disease or a couple of days in when you're trying to confirm whether this is bacterial or not. Procalcitonin in low resource settings is much more expensive, but it has a much more rapid response. And then you get into all sorts of other things which can be used in conjunction with each other or in conjunction with clinical tools. What one has to highlight in low resource settings is that if you look across this band of resources for investigation here in a number of low resource settings, you'll see that many things such as routine chemistry, testing for tuberculosis microscopy are relatively unavailable in many of those countries. And so there are limited resources there. And if you look at how those laboratories work, what you're finding is that they're actually limited. They're only available for limited hours of the day. They're paid for by parents, which is deeply problematic when it comes out of the parents' cost. And there's a long turnaround time. You can contrast that with what is required and what potentially biomarkers would be able to give us. And my suggestion is that at this stage, I don't really see too many of the biomarkers going into clinical implication in low resource settings, but there's a huge potential to use biomarkers to link with the clinical features of disease and disease presentations in those settings to help us identify those clinical syndromes and then develop the appropriate responses. We need to be looking at which pathogens are there. In the words of Carol Ennerton in a recent paper, she was saying we need to be thinking globally about sepsis, but actually act locally. And where the biomarkers and the complex biomarkers may help us is to identify in regions what the clinical spectra are likely to be and how we can identify children who need specific therapy very early and very quickly. Sadly, I think it'll be a long time before we are able to move biomarkers into a bedside tool that can be used routinely on children coming through the systems. And so finally, it's clear that sepsis and severe infection is a huge issue in the low resource settings. In fact, there's tens more, if not hundreds to thousands more children who die of sepsis in those settings than in high income settings. In order to address that morbidity and mortality, tools such as the biomarkers have huge potential, but we are going to have to adapt them to the specific pathogens, the specific populations of children there, and to try and find ways that we get the best bang from our buck. And possibly the research platform at the moment is where that's going to live. So thank you for your attention, and I'd be very happy to answer any questions.
Thank you very much. That was a fascinating talk and highly relevant. I work in Vietnam, so we have similar problems being a ELMIC country. So you mentioned about there's still quite a way off for using biomarkers, but are you currently using them, and could you ever think of a situation where it would change your management?
In our setting in Cape Town, which is probably one of the richer ones of the lower resource income settings, we certainly use some of the hematological markers, particularly band counts have been particularly useful. And if you have some of the expertise to do those, that's incredibly inexpensive. We use markers such as the C-reactive protein and procalcitonin much more as a tool for terminating antibiotic therapy or adjusting therapy rather than as a primary diagnostic feature. And I think CRP is used extensively throughout Africa in the neonatal population. And again, it has this problem that if the child's sick, for heaven's sake, don't wait for the CRP. But once you, a day or two into the illness, the CRP may start giving you some direction as to whether this is in fact a bacterial pathogen and where you can go beyond that. The rapid diagnostics for tuberculosis have brought an utter sea change in how the management of TB has been sorted. And I think the rapid diagnostics for malaria have done that. So the potential for the biomarkers, I think, is huge. Again, to help us unpick these issues of different pathogens and sometimes multiple pathogens, because you may well have, children who die of malaria often have simultaneous bacterial infections, and that's part of the problem that has to be picked up, and biomarkers may be very useful there.
Yes, I completely agree. Is there any single investigation that you would choose if you have to do one?
I think probably the one that I've found most useful has actually been the PCT, but I first have to preface that by saying that I'm in a relatively affluent one of the low resource countries. But I think the fact that it responds so rapidly, both going up and going down, means that it has more validity in terms of early diagnosis of bacterial infection. And it's certainly been a powerful tool for terminating antibiotic therapy when we don't have evidence of bacterial infection. So for the moment, that's my top of the pops. I'm very fond of the band count. I think that's been particularly useful in a whole number of studies, and that's relatively inexpensive.
Great. Thank you very much. Okay. No further questions at the moment, but we might have a general discussion at the end. So thank you very much, Andrew. That was really useful. So we're going to move on to our next speaker, who is Dr. Rita Murri. She's joining us from the University, the Catholic University of Rome in Italy, and we're looking forward to hearing her talk around biomarkers and sepsis. Thank you, Rita.
Thank you very much for the kind invitation. It's really a pleasure to be here. What we need in an emergency department, especially in a patient in which we are suspecting a sepsis. So probably we would like to discriminate between an infectious or a non-infectious disease. We want to diagnose rapidly. We want to perform a risk stratification, to prioritize resources and to optimize as soon as possible the treatment. So finally, we want to get considerable information in a very short time. But we know that an impressive number of papers are published each year on biomarkers for sepsis. So the amount of biomarkers being studied is really very high. So when we think to what to do in emergency department, when a patient is admitted with a suspicion of sepsis, I would identify at least 3 groups of measures. So first of all, blood cultures, of course, they are largely available, also in LMIC, and I thank my previous lecturer for the very exhaustive description of the use of biomarkers in LMIC. The blood culture are rapid and cheap. They can give us an ultimate diagnosis. Secondly, we would like to assess biomarkers, very largely available, rapid, and probably with some limitation. One of these is that they are not for diagnosis, but only for a support of diagnosis. And thirdly, probably I would use some other kind of measures, so scores that may be useful to predict which is the patient at high risk of sepsis. So we talked already about CRP. This is a protein that trigger complement activation, is not so useful for differentiating the different phases of sepsis. And there are controversial results on the impact of CRP for reducing days of therapy. And we have also procalcitonin with the most abundant evidences. This is already a support for the diagnosis, but we are aware that this is not a guide for antimicrobial initiation in patients with sepsis. It's a very great support for early discontinuation, even though now is really questionable because the duration of therapy is becoming shorter and shorter. And the Surviving Sepsis campaign recommend against the use of procalcitonin for the diagnostic support. However, in a study that we published in our group at Gemelli Hospital, procalcitonin was an independent risk predictor for death, but unfortunately the usefulness of early procalcitonin assessment in the emergency department in patients with low risk of sepsis remains unclear. Again, expert opinion are really clear in not supporting the use of procalcitonin for diagnostic purpose, but they underline the significant role of this biomarker in taking decision on discontinuation of antibiotics as soon as possible. In a very interesting comment published on Lancet, again, the clinical reasoning is always superior and more powerful than biomarkers, even though procalcitonin give very important information. Okay, if we look at settings where more resources are available, probably we have we should mention other tests. For example, in the microbiology kind of measures, we should mention T2 and rapid diagnostic tests with the availability also of rapid antibiogram. Unfortunately, they are not largely available. They are expensive, but they give us important information on definitive diagnosis. As you can see here, the implementation of rapid antimicrobial susceptibility testing is being shown to reduce the number of days of antibiotic that could be unnecessarily used. Again, we can have availability to use some more sophisticated biomarkers. And of course, they are pro-adrenomenulin, presepsin, IL-6, and super. They are not largely available. They are very rapid. They are expensive, and probably they are used in top-level settings, and high gas sensitivity and specificity was demonstrated for this kind of biomarkers. There is a 9 number of papers that compare biomarkers among them, sometimes with very controversial results. Here you can see a paper demonstrating the better performance of the combination of procalcitonin and CRP. And here another study in which proadrenomedulin, that is a very promising biomarker, was demonstrated to have a very good performance. Some of the new available biomarkers refer directly to different, to the pathophysiology of sepsis and the different immune endotypes that could be present at the sepsis onset. So the assessment of immune biomarkers may contribute to identify which is the immune response pattern that is prevalent in this moment. And for example, in a very recently published study, the assessment of many different biomarkers clearly identified 2 different phenotypes of people with sepsis, one corresponding to a sort of hyperinflammation, and the second with a more normal ranges of biomarkers. And in the study, the inpatient mortality was really different between the 2 different phenotypes. So we know that large areas of sepsis pathogenesis should be still explored and known. And lastly, I would like to mention also some other kind of measures. So the machine learning model, predictive models that are based on artificial intelligence. But for this kind of models, of course, electronic chart are needed. And there are still now few evidences of the impact of the implementation of such models on clinical outcomes. And we should mention also some black box for the interpretation of the model. Here at Gemelli Hospital, we explore the possibility to apply such, to study and to apply such a kind of model. For example, this is a machine learning predictive model that focused on the rapid identification of people, especially at low risk of bloodstream infection, to support antibiotics saving. For example, if the probability is very high, the model supports the immediate start of antibiotic therapy, but when the probability is very low, the model supports the watchful waiting approach. Here, for example, this is the results of our model. So in my opinion, the opportunity to analyze a huge amount of data from real world and implementing them with several biomarkers could improve the predictive value. So which could be the future? We don't know very well. We think that innovation could enlarge our view on biomarkers and on their role in improving clinical outcomes. So in conclusion, we think that biomarkers can provide timely support to clinicians in the diagnosis, and probably some of them, like procalcitonin, can significantly decrease the duration of therapy. And there are some very interesting evidences on possible role of several new biomarkers, even though the cost benefit and the real impact on the improvement should be further demonstrated. I believe that machine learning predictive models can have a very important role in the very near future, and large areas of sepsis pathogenesis should be explored. So thank you very much. If you want to get in touch for any of the things we presented, please write me an email.
Thank you very much, Rita. That was a really interesting talk. And interesting that you're also using machine learning predictive models. And you mentioned that you add other things apart from biochemical biomarkers. So are those parameters like routine vital signs, or what else do you add to the models?
Oh, we use in the models CRP and procalcitonin and blood count, so some ratio from neutrophil lymphocyte ratio. And of course, CRP and procalcitonin entered the model because they could change the predictive power of the model. Of course, we didn't implement sophisticated biomarkers because we have a few data, for example, on proesepsin to be included in a very large model such as that I presented.
Yeah, we're doing similar for dengue, so it's interesting. We should chat more. Please put any questions for Rita into the chat, or again, we might have some time at the end for a general discussion. Just also interesting that you also came to the same conclusion that Andrew did about actually the role of biomarkers in stopping therapies, and antibiotics are just as important. Do you want to comment any more about that?
Oh, absolutely. I'm really impressed too, because even from several parts of the world, we reach the same conclusion. So even if probably I talk from a rich part of the world, I think that the cost benefit of biomarkers should be carefully assessed, because only if we have a demonstration of the usefulness of the biomarkers, probably we can include it in the algorithm of our diagnostic pathway. So it's very interesting to say the similar things from several parts of the world. And of course, I want to underline that predictive models with a large amount of data are really cheap. It's incredible to think, unbelievable to think, but they are cheap. They require a lot of expertise, but so many financial resources.
There are a couple of questions that we'll quickly I'll read for you. So one person said that they had a patient with a very low procalcitonin level despite having septic shock.
Yeah, thank you very much for this question, because it underlines which is the limitation of such biomarker. For example, we think immediately to candidemia, and which we know, all of us know that procalcitonin is always 0 or very close to 0. And so again, is the clinical picture that drives our decisions and not a number. So procalcitonin could be a support, for example, when it's positive, just to support our hypothesis, or just to allow a kind of address in, for example, in etiology. We know that high procalcitonin is more often a gram-negative sepsis. There is a correlation with the gram-negatives, but again, it could be not an absolute guide.
Yeah. So treat the patient as a whole. And just quickly, last question. Somebody wants to know your opinion about IL-33 as a possible biomarker.
I don't know. I have no experience on IL-33, absolutely, so I cannot say anything. The second question, blood cultures are not rapid and very expensive in low research settings, and patients pay for this. I completely agree, and unfortunately, I'm not expert in studying which is the most rational way to put together all the resources, the available resources in LMIC. Probably my first lecturer can better answer to this question. But I completely agree. So probably it's our duty also to study together cost-benefit analysis.
Exactly. I think that's a great place to end, and maybe we can have further discussion at the end. But thank you very much, Rita. That was really excellent. So we're going to move on to our next speaker now, Professor Chris Seymour. Chris is an associate professor of critical care and emergency medicine at the University of Pittsburgh in the US, and is going to talk to us about clinical phenotypes in sepsis. Chris, thank you.
Great. I hope everything's coming through okay. It's really a pleasure to join you today. And of course, thanks to our sponsors by Murri, and it's been enjoyable, the first two speakers. Everything looking good. So yes, I was asked to speak a little bit about clinical subtypes in sepsis and what they might suggest. And this builds a lot on some of the biomarkers that have been discussed, and even some of the machine learning tools that Rita was discussing in the prior talk. So I have just these conflicts from some consulting, the NIH, and a member of Surviving Sepsis Campaign, and do work at JAMA. Okay, so my research is primarily in sepsis, and I like this quote that you can't play a symphony alone. It takes an orchestra to play it. And I think you'll understand why I'm sharing that towards the end. I'm going to talk a little bit about what I think a subtype is in these short 10 minutes, a little bit of a comparison to other fields, and then a couple potential paths about how we may use them. Okay, so when we think about subtypes, I also like this bit of writing from Jeremy Berg. He used to be the NIH director and is now at the University of Pittsburgh. And he was referencing this concept of lumping and splitting. And I won't read this, but he does go through and share that there are important, differences, at least in oncology and in a tumor per se. And he talks about if we think about lumping patients with certain characteristics together, it may obscure important biologic or clinical differences. Whereas if we split them into smaller and smaller groups, it might give us too many categories and insufficient information about each one. And it's interesting to think about how that might apply to sepsis. But this issue of sort of overlapping categories isn't new. It's always fun to think about what our taxonomy colleagues have done. They think about animals like the platypus that fit into multiple different types here that may have features of birds, may have features of mammals. And it's a very interesting animal to think about, but it's also sort of represents all of our sepsis patients. They have some characteristics of some groups. They may have a biologic signature that resembles a certain immune phenotype, but may also have a source of infection that's very clear from a different group. And so there's a number of approaches that have been presented. In such short time, I thought I would just put up two very important references. One is a framework for developing and interpreting sepsis subclasses or subtypes by Kim DeMerle. That was from a few years ago. And then a most recent piece by Manu Shankahari and a variety of other authors here in Lancet Respiratory talking about sepsis immune biology. I think these are two good places to go for more detailed reading and then really a discussion of the challenges and opportunities here. And what these two reviews are sort of chatting about tend to be sort of data like this that's shown. And so here on the top is whole blood gene expression from Tom Vanderpoel's laboratory in what was called the Mars cohort. And so these are patients in the intensive care unit at AMC, and they had blood biomarkers measured across multiple domains. And then using machine learning, they were identified in an unsupervised way to be members of 4 different classes. And they had different clinical characteristics and different outcomes. These transcriptomic subtypes of sepsis, as alluded to by Andrew in the beginning, have been looked at across multiple cohorts and potentially have different treatment response, although they're sort of being tested in randomized trials now. And Evangelos will talk to us about that at the end. Down at the bottom is just a screenshot of a figure from a paper we published in JAMA about clinical subtypes of sepsis using machine learning applied to clinical data in the electronic health record, where again, using multiple different models and 6 different cohorts of patients, we're able to identify subtypes named alpha, beta, gamma, delta. And it's sort of stage of sepsis research that we're at is a bit sort of represented by the Kandinsky painting on the right, where we have a variety of overlapping circles, some of which may meet at the borders, and our patients are sort of members in all of these, but there's really not much organization going on. And in fact, there's more and more subtypes of sepsis being presented almost every day. We just saw that recent paper in Scientific Reports that Rita shared. So this is a plot over the last sort of 50 or 60 years put together by Kim DeMurrell, showing how both COPD, asthma, and sepsis have had a rapid increase in the splitting, not the lumping, but the splitting of patients into multiple different groups. Jason Kennedy's a researcher doing a systematic review and meta-analysis of these groups, and he's sort of up to the number of 189. So the most rigorous approach we've seen to just cataloging how many subtypes of sepsis are presented has us almost near 200. And it's a bit of this sort of phenotype anarchy. This is a piece that describes sort of the challenges here and draws from another beautiful perspective called taxonomic anarchy that was in Nature many years ago. And there really are so many parallels to the challenges we're experiencing as sepsis becomes smaller and smaller and smaller groups to what's happened in our colleagues in biology and taxonomy. Hopefully, we would find some groups that are biologically plausible, that we can reproduce in different data sets, that are non-synonymous or don't overlap, and ultimately are treatment responsive. One issue, though, as we keep presenting new subtypes, has been highlighted in this paper by Lanneke van Vogt, also a trainee of Tom Vanderpoel at AMC. And this alluvial plot's very complicated, but it's taking ARDS subtypes, hypo or hyperinflammatory, on columns on the left and mapping them to either Seneca subtypes or Mars or even the SRS subtypes that also are of a transcriptomic signature. The point of this figure is to show that proportions of patients in one group can spread across all the other groups, and there's really a lack of agreement in many respects in these subtype labels. When the different biology, when the host response biomarkers are then mapped across these different group labels, we also see quite a bit of difference. And in the most important figure in this paper, I think was figure 3, where the blood transcriptome was also shown in this heat map across the different subtypes, which are the column headings at the top. And you can see very different pathways with over or underexpressed genes across subtypes, really no distinctive message here. Okay, and so these can be even further grouped into sort of subtype ensembles, so to speak, and that's what was shown here at the end. So I'm going to wrap up by just showing an example from oncology. Time is short, and so this is the most recent precision medicine paper, the New England Journal, in the oncology field, and it's testing capivasertib. And the reason I bring this up has nothing to do with the drug, but rather to look at the methods. And if you start to go through and evaluate the patients that were selected for this randomized trial, you see that they were hormone receptor positive, HER2 negative, with advanced metastatic breast cancer. And then they had very specific criteria for how those biomarkers were measured. On top of that, the patients with those biologic profiles needed to have disease progression on the aromatase inhibitor, already have had chemotherapy, prior CDK4/6 inhibitor, and 2 lines of endocrine therapy, and no exposure to a different drug. And on top of that, they had to have lytic or mixed lytic blastic bone lesions. They had to have a performance score that was assessed here, and tumor molecular analysis performed showing different activating mutations of the tumor itself. Okay, and if you put this into sort of categories, you'd see that in order to just get into a single precision medicine trial of a single drug, these patients have all of these criteria met that span the clinical, the biomarker, the trajectory, treatment exposure, disease burden, performance status, and then molecular sequencing of the tumor. Okay, so imagine this was sepsis, and we had to enroll the same or find a similarly precise population. We would be trying to do a trial in a patient that had to meet all of these criteria, that not only their age or their lactate and IL-6 had to be elevated, but they would have had to already have failed a course of treatment with Zosyn, received fluid, have a visible abscess, could walk a flight of stairs, and on top of that, have a transcriptomic profile that fit perhaps Mars2. And you can see that if we put this into words, this is an almost unattainable population to enroll in a randomized trial. Okay. And the message here goes back to that musical analogy at the front, in that instead of focusing on a specific subtype or sort of group of musicians in the orchestra, we really need the whole set in order to identify our patients. And that's again shown in another heat map from the Mars Consortium, again showing how these subtypes are all overlapping. And perhaps there are sets of patients inside this heat map that we need to target in our trials. So this is the wrap up, and I'll just say that subtypes are common. They're capturing different information, and that's not surprising. And we should be embracing clinical subtypes in the same way we're embracing transcriptomic or biologic subtypes, but then think about how they combine together. And it's those combinations that I think we'll see in some of the trials Evangelos is running, and along with others, that find us treatment responsive groups. So thank you for your attention. Certainly happy to answer questions. And thanks to NIGMS for funding this work and others.
Thank you very much, Chris. That's some great work. So are we still in the position where this is being used as a research tool or for enrollment into trials? We're not really at the clinical validation stage yet.
Yeah, I think you're right. I mean, to go back to the sort of art analogy, we're very much in a Rothko phase at the bedside. There either is sepsis or there isn't, or there is septic shock or there isn't. And all of the different subcategories and subtypes that we discussed here are being, I think, looked at in two ways. One is to either further understand the underlying biologic mechanism in a discovery way, or to find very parsimonious models that can be used for trial enrichment, randomized trials, enrichment strategies.
Yeah, I think that's absolutely right. And are you actually using any of these clinical phenotypes for recruitment into trials at the moment?
Yes, so that's a good prompt. It looks like there's no further questions. I know others want to speak, but NHLBI has funded now 2 randomized trials that are using clinical subtypes that can be identified at the bedside to help unpack heterogeneity of treatment effect.
Great. Well, on that note, we're going to move into a talk about clinical trials. So thank you very much, Chris. That was great.
Thank you.
So yeah, on to our next speaker, who is Professor Giamarellos-Bourboulis, who is coming to talk to us from Athens about using biomarkers as endpoints in clinical trials. So over to you, Angelos.
Well, thank you very much for the introduction, and I would like to thank wholeheartedly Chris Seymour for quoting our research and the expectations which are coming from our ongoing immunosec trial. Today, I would like to elaborate on something completely different. Whether biomarkers can be used as an endpoint of treatment effects, which at first reading appears as rather bizarre, rather odd. So in other terms, we are giving treatment just to decrease biomarkers, or in the very end, what's going on is that if we manage to have a biomarker, it can either be a laboratory or a clinical, and this is improved, then this ends up with significant overt follow-up of the patient, clinical improvement. This is my conflict of interest disclosure for this presentation, and allow me to start with a question which is coming from the existing and published 1 year ago guidelines, coming from the European Respiratory Society, the European Society of Intensive Care Medicine, the European Society of Clinical Microbiology and Infectious Diseases, and the Thoracic Society of Latin America. What should be the treatment of severe community-acquired pneumonia? What you see is the pico question. Should we deliver empirical treatment for severe TAP with a combination of beta-lactam plus macrolide or a fluoroquinone? And can this reduce mortality and adverse clinical outcomes? The answer is positive. However, the recommendation which is given is conditional and is relying on a very low quality of the evidence. In other terms, there is something missing. Why we have this low quality evidence recommendation? Allow me to elaborate to you on a paradox here. So the guidelines are suggesting, and this is based on meta-analysis, that when you treat severe community-acquired pneumonia, you need to treat with a macrolide. But look at the map of the United States having to do with the resistance of Streptococcus pneumoniae to macrolides. So how is it possible to have treatment benefit or to suggest to give treatment by using an agent which is adding a resistance? Allow me to elaborate to you with the question macrolides to add or not to add on a recent meta-analysis, the most recent meta-analysis, trying to dissolve that if you compare patients empirically treated with for community acquired pneumonia with a macrolide or without a macrolide, whether you may achieve better attainment of pneumonia resolution or decrease of 30-day mortality. And there is no doubt, as you may see from the meta-analysis, that indeed at the test of cure visit, the likelihood for resolution of pneumonia goes up, but also the risk of death after 30 days goes down. So the question comes, how is it possible with this type of meta-analysis, which are including almost 60,000 patients, more than 30,000 in the non-treatment arm, something less than 30,000 in the treatment arm, that we have a very low quality of the evidence? And the answer is, look at each and every single study included in the meta-analysis. How the confidence intervals of the odds ratio, they cross to the vertical axis, which means that none of these trials is of such quality to provide clear-cut directions and clear-cut guidance. In other terms, let's try to elaborate a different type of evidence. An evidence which is rapid, the first 72 hours, and which elaborates on decrease of symptom intensity, an improvement of organ dysfunction, and an attenuation of inflammation. Let's see where the biomarkers, the first biomarker, intensity of symptoms. This is the respiratory severity symptom score. Each and every patient is given score points from 0 to 3 if the symptoms are absent, extremely severe, mild, or somewhere moderate. And the symptoms which make part of this scoring are cough, chest pain, shortness of breath, and sputum expectoration. So this is the first one, clinical one. Now let's move to the most common biomarker which we use in everyday clinical practice, the SOFA score. So if we want to have an early improvement of organ dysfunction, we need to have a decrease of baseline SOFA score. And the third, which has to do with the attenuation of the inflammation, let's consult procalcitonin. In other terms, we have a readout of PCD before start of treatment. We repeat that after the short time point, the 72 hours, where we want to achieve an improvement of the cost. And we elaborate one of these scores, which are considered as an indirect proof of the improvement, even leading to stop of antibiotics by using procalcitonin. So allow me to acquaint you with the results of our ACCESS randomized control trial. It was published in Lancet Respiratory Medicine in the issue of this month. It's online since last January. Adults who have radiologically confirmed pneumonia, so far more than 2, at least 2 signs of systemic inflammatory response syndrome, procalcitonin more than 0.25, and at least 2 of the 4 symptoms of cough, pleural sphere, dyspnea, or pleuritic chest pain, they receive either standard of care antibiotics plus oral placebo every 12 hours for 7 days, or standard of care antibiotics plus clarithromycin orally, 500 milligrams of clarin every 12 hours for 7 days. And there is a very intense daily follow-up of our patients. And we elaborated for that a composite score which comprises all the elements I talked about. In other terms, we want the first 72 hours to patient to experience an at least 50% increase of respiratory severity symptom score, and that this, on top of that, the patient experiences either an at least 30% decrease of SOFA score or an at least 80% decrease of baseline procalcitonin. In that point, procalcitonin could equally well be less than 0.5 nanogram, 25, nanogram now. This is the flow chart. In the intent to treat population, we had 133 patients allocated to treatment with standard of care antibiotics and placebo, and another 134 patients allocated to treatment with standard of care antibiotics and clarithromycin. Look, what are the main elements and characteristics of the patients to whom we deliver treatment? They are elderly. They have severe comorbidities, as this can be seen by the Charles's comorbidity index. The median PSI is far beyond 90. 90, I remind you, is the cutoff for severe pneumonia. Here, the median value is 122. The SOFA score is increased. The same is the case for VCT. Almost 30% of the patients, they suffer from pleural infusion, and the vast majority, they have hypoxemia. The primary endpoint is strikingly impressive. Almost 70% of patients allocated to treatment with standard of care antibiotics and clarithromycin, they achieve the primary endpoint, compared to less than 40% of patients receiving placebo plus clarithromycin, and this is equal to a 3.4-fold improvement of the patient. However, the real question is, we elaborated an endpoint based on the biomarker, but is this still clinically significant? Because if it were clinically significant, this means that because these patients are suffering from severe cough, they should have an attenuation of their progression towards organ dysfunction. And yes, indeed, this is the case. 17.3% of patients receiving standard of care and placebo, they end up in the ventilator and in the ICU, compared to only 6% of patients who end up in case when they receive treatment with clarithromycin. And if this still is the case, what we want is not just to achieve a decrease of the progression to the ICU, but we want that the patient, in order to get his pneumonia resolved, that he does not jump into secondary sepsis. And this is the progression of the patient to a new infection plus increase of the SOFA score, which is happening in 24.1% of patients receiving standard of care and placebo, and it goes spectacularly down to 13.4% among patients treated with clarithromycin. So, if there is no progression to organ dysfunction and no progression to secondary sepsis, then the patients should leave the hospital earlier. And indeed, this is the case. 79.1% of patients treated with standard of care and placebo, they leave the hospital earlier compared to and alive, compared to 62.4% of patients receiving treatment of standard of care and placebo. So allow me to jump into our main conclusions. By using a combination of biomarkers, clinical and laboratory, we managed to deliver the first randomized controlled trial to prove an early clinical anti-inflammatory effect of the macrolide, in our situation, clarithromycin for community-acquired pneumonia. And the biomarker defines earlier resolution of symptoms, earlier resolution of organ dysfunction, and early attenuation of the inflammatory burden. And achieving this composite score, but early achieving this composite score using the biomarkers, is translated to spectacular clinical benefit. Decrease of progression to organ dysfunction, decrease of the incidence of sepsis, and earlier hospital discharge. With this, I would like to thank you very much for the invitation, and I'm looking forward to take any questions.
Thank you very much, Evangelos. That was really amazing and game-changing results. I know you did similar work in COVID using SUPAR. Could you just briefly describe the work around sort of enrollment into trials? So apart from using biomarkers as endpoints, but also as sort of stratifying patients into particular treatments.
Well, thank you very much for this excellent question. Actually, in the trial that I just narrated, what we did is that we targeted a specific phenotype of a patient who, by using some very well acceptable clinical criteria, we realized that he's borderline, he's at risk, he is actually septic, he's not yet in the ventilator, and actually what we want is to have his inflammation attenuated to prevent ventilation and to prevent secondary sepsis. Regarding what you said with COVID-19, what attracted our attention was from the very beginning was that we had patients arriving in the ED, and some of them, they had a good outcome. And all of a sudden, other patients, at the beginning of the pandemic, they were appearing well. After 8 hours, they were coming back, and they were in need of ventilation. So that means that there was a secret which can differentiate between the ones and the others. And our idea was to identify a biomarker who does not just predict the likelihood of this, but who can also demonstrate to us the pathway which leads to deterioration, so as to give immediately, just because the biomarker is increased, a treatment to attenuate the pathway.
Yeah, completely makes sense. Thank you for that. Any questions, please put your questions for Evangelos into the chat. Just give them a few minutes. Did anakinra become standard of care in your setting for COVID?
Yes, it does. And it is in our guidelines for patients with COVID-19. And actually, what Chris Seymour was mentioning earlier is that we are waiting now the months to come, the readout of our big immunosub trial, where we delivered precision immunotherapy in patients with the endotype of macrophage activation-like syndrome. They received either placebo or anakinra adjunctive therapy, and patients with the endotype of sepsis-induced immunoparalysis, on top of standard of care, they received adjunctive treatment either with placebo or recombinant interferon. So the idea now is in patients who are already ventilated with bad prognosis in the ICU, whether targeting the two arms of the spectrum of pathogenesis, the extreme hyperinflammatory and the extreme hyperinflammatory, whether we may reverse the clinical progression.
Absolutely. I think it complements Chris's talk very well. So understanding the pathogenesis and the phenotypes to then guide the treatment is probably the way forward, isn't it?
Well, I see a question coming in the chat. I don't know if we have time.
Yeah, briefly, yes. If you could answer, could the data also be transferred to other macrolides?
I would very much like to answer yes, but it's impossible to answer yes, because the other macrolides, they have different PK, PD, so separate randomized control trials are needed for each of the macrolide drugs.
And can you comment on the mechanism of action is anti-inflammatory? So what about using other?
Thank you very much for this. It is on the publication that the secret is a restoration of the immunoparalysis which dominates community-acquired pneumonia. Contrary to the pneumonia of COVID-19, which is a pro-inflammatory pneumonia, it seemed that our patients, they were on a state of exhaustion of monocytes for the production mainly of TNF. And that was fully restored among macrolide-treated patients. And we believe that this is associated with better phagocytosis and better clinical outcomes.
Brilliant. Okay, I'm sure there'll be more questions, but maybe you want to write it in the chat because we probably need to move on to our last speaker. But thank you very much. That was fascinating. So our last speaker is Sylvie Pons, who is talking to us from France. She's from Biomarkers, and we'll be talking about reducing antibiotics in neonates using biomarkers. Thank you, Sylvie.
Thank you, Sophie, for the introduction. I am pleased to present the results of the EMERAUDE study, which was initiated in the interest of reducing the use of Antibiotics in hospitalized newborns. First of all, some facts about neonatal infections. Neonatal infections are very common in premature babies. Regarding the neonatal infection, they are very common in premature babies, especially among the very low white babies. And this infection remain frequent due to the multiple risk factors, and they are often severe. As you know, we have two classifications for this sepsis in a neonatal context. First, depending, and this classification is linked to the baby's age. So before 7 days of age, EOS is defined as infections after exposure to pathogens transmitted by the mother. And these EOS are rare, but the prognostic is severe. And after 7 days of life, the infections occurring as more nosocomial and largely due to Staphylococcus. They are very frequent in very small babies, and such infections are classified as late onset sepsis. And the EMERAUDE study was set up in this context of loss. So despite the high prevalence of loss in ICU, the diagnosis remains difficult because the clinical signs of suspected infection are unspecific and inconsistent. And in addition, with the blood culture, which is the current gold standard for the diagnosis of loss, there is a risk of false negative results if the sampling volume, for example, is not sufficient or in case of contamination. And some biological markers can be used in routine by the clinician to help with the diagnosis, but they are not early enough and lack of specificity. As a result, the clinician often give to neonate probabilistic antibiotic treatments, which can have a side effects for newborns and impact microbiota development, potentially leading to antibiotic resistance. So the EMERAUDE study was initiated to address these difficulties. And the aim of this study was to identify a biomarker combination to early exclude the diagnosis of loss in a newborn with suggestive clinical signs of infection. The clinical study was conducted in 2 French NICUs, and patients were included over a 3-year period. The inclusion criteria for patients were age greater than 7 days and signs of suspected infection. And at the same time of the blood sampling for standard of care, an additional small volume was collected for the dosage of the biomarkers. 11 protein biomarkers were selected based on literature data in the context of loss, and most of the assays had been performed using the ELA multiplex immunoassay platform. And after that, an adjudication committee of 3 independent neonatologists classified the patients into the different group, so infected, not infected, or unclassified group. And these experts were blinded to the biomarker data. After that, statistical analysis with the outcome was performed to determine the performance of the biomarker alone or in combination. So regarding the population, 234 patients were included and 230 patients were analyzable. 51 patients had a confirmed infection, and finally 26 patients could not be classified by the adjudication committee. Suspicion of loss leading to inclusion occurred at a median age of 14 days of life, and the patients were mainly preterm with a median gestational age of 27 weeks, and 80% of the patients were very low birth, white babies. And finally, 15% of the patient had a surgery before inclusion. Regarding the clinical management, in fact, half of the neonates were treated with antibiotics, but the most important point is that all of the neonates with infection receive antibiotics treatment. But we noticed that 27% of the not infected neonates were also treated by antibiotics, confirming the need of biomarker to exclude the presence of infection in case of suspicion of loss. That means that, in fact, neonatologists do not need help to recognize through bacterial infection, but they have difficulties to identify the not infected patients. We combine three clinical variables in a model and we assess the performance of this clinical model. And in fact, the AUC obtained was close to 0.5. Confirmed the need of the bad performance of the clinical model and the need of biomarker with very high negative predicted value for the diagnosis of infection. Regarding the biomarker doses, we notice we have noticed differences, notable differences between infected and not infected groups. Especially for IL-6, IL-10, and NGAL. And furthermore, we observe that the biomarker profiles of the unclassified group were very similar to that of the infected patients. The statistical analysis was performed with the two groups between the infected and not infected patients. The unclassified group was not considering in the analysis. And for the biomarker alone, IL-6, IL-10, and NGAL show the best AUC close to 0.8. And for the combination results, the best performances were obtained with a combination of PCT and IL-10, PTX3 and NGAL, and for this combination of three biomarkers by adding gelzoline. We observed that the AUC were very similar between the combination to up to three biomarkers and with the biomarker alone, showing no added value of implementation of a biomarker in the combination. Then, using these six best model of biomarker in the group on the not infected patient but treated with antibiotics, we compared the adjudication and the infection status obtained with this model. And with the model combining PTX3 and NGAL, we found that up to 64 patients who received antibiotic would have been identified as not infected by the model. And the performance of IL-10 was also very close to these results, and IL-10 alone would have correctly reclassified 62% of the not infected patient and potentially avoid to give unnecessary antibiotics to this baby. So in conclusion, these results were published and shows the potential to avoid a lot of antibiotics with a single-host biomarkers. Regarding the perspective of the study, the first one is to validate these results. And we have set up a new study called Ruby for validation of biomarkers performance to reduce antibiotics overuse in newborns with suspected clinical signs. And the objective of this study is to validate the performance of the best biomarker in serum sample. But we have also set up the study with 2 additional samples, and especially with 1 sample of saliva to address the performance of the biomarker in this sample and see if the biomarker are correlate with the serum. And we have also a small additional tubes to evaluate the transcriptomic biomarkers. And this study started last December, and we have planned to include around 300 patients over a period of 30 months. The second perspective is to set up a randomized control study and to compare the performance of IL-10 and standard of care. But for that, we need a point of care with this assay validated for the IL-10. And the long-term objective, of course, is to reduce antibiotic use in NICUs to decrease the impact of antibiotic treatments in neonates. Thank you for your attention.
Thank you very much, Sylvie. That was really interesting. Can I ask, was it just one single time point used, or was it over several time points? Measuring the biomarkers, did you have several time points, or was it just a admission?
No. For the EMERAUDE study, we have just 1 time point, and for the validation study also only one time point. Yeah.
And is that something you consider doing, just to look at the trajectory of the biomarkers? Just
no, we have not planned to have several time points.
Okay. Just, I mean, obviously sepsis is a dynamic disease, and it changes fast, so it might be just something we've looked at, and actually the trajectory of biomarkers is actually really interesting. But I think your data is fascinating. You mentioned the rapid test, because at the moment the turnaround of time, is that an option? And could you get a rapid test with all 3 of the lead biomarkers?
The best option will be a point of care assay, but for the moment there are not available assay in this type of platform for IL-10, for example.
Yeah, I think that is a hope, and hopefully the next step. So thank you very much, Sylvie. That was a really excellent talk. Did you have any patients who might have had a viral infection in your study, Sylvie? And if so, what were their biomarker profile?
No, we have no patient with a viral infection, no. And
for the infected patients, which antibiotics were they put on? And what's the possibility that the antibiotics the biomarker?
The most common antibiotics is vancomycin. The first one for the treatment is mainly vancomycin.
In that case, if there are no more questions, it's just I'd just like to thank all of our speakers who have given a really wide range of talks on various aspects of biomarkers and their utility in clinical practice and also for clinical trials. I think it's been an amazing session, and thank you all very much. And yeah, we'll see you soon. Bye-bye.